So while everyone settles, let's start. Let's not delay. I think this is a huge rainy day and a lot of things are going on. So we will discuss about the 5 years reported overall survival data which has now become available with ES-SCLC. For the first time in small cell lung cancer, we are again discussing 5-year data. So a few hours back, we discussed 5 years data with ALK, which has now come, and that is a game changer. Similarly, now we have a 5 years data with ES-SCLC, and now hopefully after 3 to 4 years, we'll have 10 years data for multiple cancers. We'll be able to discuss in subsequent master classes. So that is another thing which we are looking forward to it. So this is what we know. Drug development in small cell is always a challenge, and multiple trials have failed to provide any significant benefit. So Samir boss, I will request your comments. The available treatment options apart from immunotherapy, we'll not discuss for immunotherapy for a few minutes, then we'll shift to that. The chemotherapeutic options which you utilize in the real practice for treating small cell lung cancer.
I think it is very limited, and last 4 decades it's the same platinum-based combination. Nothing new is there in terms of chemotherapy.
Yes, nothing much. Thankfully, I think lurbinectedin is going to come in India shortly. In around 3 to 4 months, it is expected. So it will be an additional option which will be available to us, but not sure. Okay, he's joined. Dr. Pratik, are you there on Zoom?
Yes, I'm there.
Okay, thank you. So yeah, so thankfully we have lurbinectedin will be available, so that we have something good for second or third line treatments, because irinotecan and taxanes are there. We utilize irinotecan in a lot of patients, but taxanes, a doubtful benefit, whether to utilize it or not, we are not so sure as well. So comment on the second line therapy if the patient is progressed. I think Kunal, you can take that.
Yeah, so the second line dilemma remains that we have not a very good effective agent so far, and with lurbinectedin coming in, and plus I think world is moving towards DLL3 also, but that will be too far for India. So yes, there is a dearth of second line options. And plus here the NGS role comes into play, because you have seen some patients with RET or BRAF somewhere.
Yeah, yes, I completely agree. So Dr. Pratik, I would like to ask you, what is the main problem in small cell lung cancer when you see a patient, the initial problem and the problem of sustained response? I want you to highlight those two problems for our attendees.
So generally the patients who present to us with SCLC are usually in the extensive stage. That is because these are central tumors. The symptoms do come very, very late. They are very aggressive in their presentation, so gives a very short window of time for the patient to present to the hospital. And the other thing is, obviously the patients, all of them are not very well in the performance status when they present to us in the extensive stage. So that is one problem where we cannot start the therapy for these patients at the suitable doses according to their BSA. And again, the financial issues in India with immunotherapy. So sometimes we have to just depend on the platinum doublet, that is etoposide plus carboplatin or cisplatin in these patients.
Yeah, completely agree. So the two main points, one is a very high disease burden at the baseline. Second point is, we know platinum response, patients respond well to the platinum, but the responses are not well sustained. So sustaining the response remains an important issue in small cell lung cancers. So that is another point. Thankfully, the immunotherapy costs have come down with various access programs, but yet I completely agree, it is not still accessible to everyone, but definitely it has come down now. So let's start with a case so that we can bring about some more points related to the discussion. A 48-year businessman, heavy smoking history with chest pain and breathlessness. Since we are in an oncology conference, I don't think nobody will have any doubt. No significant past medical history. Referred to cardiology team. This is what usually happens in a general setup. The patient gets under workup by a pulmonary physician or a cardiologist. No cardiovascular abnormality was found. Mediastinal disease, you can see a mediastinal mass was found. Right lung changes and lung metastases were clear on this image, as you can see. So a CT-gated biopsy was done. Small round cell tumor was confirmed on pathology, and IC confirmed it to be small cell cancers. Thankfully, MRI brain did not show any metastasis. So now again, a problem which can be discussed. Dr. Kaushik, would you like to highlight the problem of brain metastasis in the patients with small cell?
Yeah, definitely, sir. We know it is an aggressive tumor, and major patients do present with the brain metastasis, and we know and being asymptomatic is again a common presentation in this set of people. So ruling out, still there is some plus minus data, but usually baseline brain MRI brain is recommended for usually the one who is having extensive disease.
Definitely. In the baseline settings, both in ES and LS, it is recommendation to do at least a baseline MRI brain. Subsequent, we can have discussion with the patient whether the patient is compliant enough to do MRI surveillance versus PCI. These things are discussed, but yes, I completely agree. Baseline scans are mandatory. This patient has SVC compression, which is one of the important problems which we were trying to discuss. Wheeze and dyspnea on exertion, performance status plus 1 to 2. So now these are the various options available. And we see that this is a high tumor mutational burden. So if we see this curve, this graph actually, this is an important graph which we are seeing from the time of our training in Devita book. So any comment on this? Samir boss, you would like to comment on this graph?
So definitely, like we usually see immunotherapy working well in melanoma, lung cancer, bladder cancer. Now we have GI cancers also where immunotherapy is working well. So this all data correlate with the tumor mutation burden we get in all these malignancies where we see this wherever the immunotherapy is working, tumor mutation burden seems to be higher.
Yeah, that's a clear message actually. So TMB high, there is a general understanding that the immunotherapy is going to add some or the other benefit to the treatment, which was see. Melanoma was the first where the immunotherapy approvals were there, followed by lung, then small cell lung also get. And this is sequence is matching with the tumor mutation burden levels actually. So that is what we saw in the practice as well. So this is the various trials which came in the first line ES-SCLC. It's a large slide, so you can just highlight that Atezo plus chemo was the first chemotherapy regimen which has got approval by both EMA and FDA for first line treatment. So going further ahead, this is IM power of 133, which we are seeing from the slides from last 5 years actually. So this is Atezo plus carboitopo versus placebo, and Atezo maintenance was given till progression. So now again, one important concept which I want to discuss is immunotherapy till progression or immunotherapy at finite period of time. Kunal, can you take that? Where you would like to stop immunotherapy, patient is on doing good on maintenance, some cutoffs you do in the routine practice, or you go on 3 years, 4 years, 5 years?
Yeah, so there is some indirect data that around if patient is having no evidence of disease and at 2 years there could be a possibility where we can stop by also aided by collaborative markers like ctDNA or something in certain situations, but in small cell where PFS is very low, we have to continue till progression.
Okay. So I think an important point which Kunal was trying to bring about the ctDNA. So I think that is the future which we are looking at, especially in the lung cancer adjuvant settings, EGFR positive lung cancer. ctDNA based testing can be a very important pathway because we have the LAURA trial available which shows that give TKI till progression. Other side there is another trial, ADORA trial, which says stop at 3 years, and we are seeing the graphs dipping after 3 years. So I think ctDNA is very important. Whether it will be successful in small cell lung, we don't know, because small cell is somewhat different ball game altogether from other lung cancers, but that is a very good thought. But the point which I tried to bring about is about the finite duration of treatment in a metastatic setting versus continuing till progression. As Kunal said, this is a disease with limited treatment options. Patients do not do very well. Usually, even after addition of IO, we do not see usually PFS more than a year or so. That is difficult. But we have some patients who do very well. These patients are outliers of the usual curves. And where to stop them? Because since we have utilized in a large number of patients, we have a few patients where the patients have crossed 2 years of immunotherapy maintenance as small cell also. So when to stop, where to stop, that is not clear. But what we extrapolate it from the other data sets which are available to us, we generally take a cutoff of close to 2 years. If patient has done well for 1.5 years, the disease has become very redundant and small, the patient has no new lesions coming up from the last 6 months, then we can give option, we can discuss, though we'll definitely highlight that till progression is the guideline, and it is your final decision. So I think that is the way the oncology is involved, and it will continue evolving more, and it will continue to amaze us how we treat our patients. So 4 versus 6 in the clinical practice. Dr. Patil, first I would like to go to you, then I will ask Darshit as well. Dr. Pratik.
So it's clear. So I like to go till 6 cycles in my clinical practice, because as we have already discussed, the burden of disease is very, very high when the patient presents. And given the fitness of the patient, if the patient is tolerating it very, very well, I like to proceed till 6 cycles.
Okay. Darshit, your comment?
Yes, I completely agree. I think 6 cycles of etocarboate is
Okay. I think as Dr. Pratik highlighted the point, if the patient is tolerating well, continue up to 6 cycles. That is what we do. All of us will agree. But if patient is having significant myelosuppression, patient is requiring dose interruptions, I think it is also fine enough to stop at 4, because it is the quality of life that matters most to our patients, and we should not be just fixed upon that we have to give 6 by anyhow. But if patient is not tolerating it well, we can consider reducing the numbers of cycles before reducing the doses and then continuing the treatment. Again, another point, carbo versus cis. Kunal?
Yeah, so I think any of the platinum agents can be used here. Important is to use a platinum agent, so I think they can be used.
Both are allowed in US. And Dr. Kaushik, do you agree or any change?
Yes, in real world practice, actually we are using more comfortable with being using with the carboplatin.
Carboplatin most of
the patient, I see the trial here, the PS0 patients are around 60-70%, but hardly we get in real world.
Yeah, completely agree. A very important point. So most of the time we end up utilizing carboplatin in the routine practice. Cisplatin, though we know that somewhat it is faster acting, but overall results are the same in a small cell cancer with either we utilize cisplatin or carboplatin. That is the important message for all the attendees and everyone. How to do dose reductions in elderly? Would you do dose reduction in every patient for elderly patient? What you will do, Darshit?
Sir, I would start with maybe 70% dose.
Okay.
And maybe carboplatin AUC 4 or 5. Tolerance is fair, then I would be escalating to full dose from second onwards.
Okay, okay. That is what we very fairly routinely do. Disease burden high. Patients have a compromised performance status, compromised nutrition. Also sometimes creatinine levels are high, albumin are low. It is difficult to start at the full dose. But yes, if the patient is PS1 or 2, would you do a geriatric assessment, Kunal? So now, since we do geriatric assessments in so many patients and it is just beside our thoracic OPD, what do you suggest?
So I think genetic assessment is necessary, but at times it is more on a subjective assessment, like Dr. Rashid said. But yes, we should move towards giving objective criteria, like basic tests like get up and go test, and the basic screening tools can be definitely used in place of comprehensive assessment.
Yeah, so that's a very important message. So geriatric assessment doesn't mean you have to do complete comprehensive geriatric assessment which takes an hour, but you can do some at least basic important simple questionnaires and tests so that you can get a good idea what is the actual status of the patient. It doesn't depend entirely upon the length and breadth of the CGA. So again, in this trial, we know that atezo was given in combination with carbonatopo over 4 cycles at recommended doses. And this is, if we see the rationale for administering 4 cycles, it was that there was no additional benefit of adding 6 and 5th and 6th cycles, and time to progression remains somewhat similar. This is the rationale given. I think this seems fine to me if the patient is, by chance the patient's tolerating treatment well, we can go up to 6 cycles, but otherwise most of the times with the platinum full dose, if we are giving AUC 6, we are giving most of the time after 4 cycles the patients will start developing myelosuppression, which is what is very clearly known. But if we start AUC 5, AUC 4, this is what actually happens. The patients are able to get most of the time to 5 or 6 cycles. So that is a different schedule and doses which we utilize in the routine practice. So that was the rationale. So this patient was started on atezo plus carboitopo and completed 4 cycles. No significant adverse effects. Alopecia will be there definitely. Performance was good. Continued on atezo maintenance. And this is what we see whenever we are discussing the immunotherapy trial. I think the end point in most of these trials are overall survival. So this is another very important point. When we are discussing even advanced cancers, our endpoints are most of the time it is overall survival, not progression-free survival, especially with immunotherapy, because immunotherapy is known to give benefits delayed, and PFS might remain somewhat similar. Even the median values are not very good indicating markers for the responses to the treatment, and it is the OS, and that also OS at a particular time point. So Dr. Pratik would like to add a comment related to this endpoints in these advanced cancer trials. Dr. Patil? Else I will request Dr. Kaushik.
So definitely, sir, the OS being the gold standard for us in any trial. Just thought of in this thing, the Kaplan-Meier, sir. Initial 4 to 5 months, almost both the curves are almost inseparable over
yes,
here.
yes.
And then only those who are responders are having the gradual separation of the curves. And they are the one who's getting the bonus benefit.
So yeah, actually this is what we see here in this curve. That is what is being highlighted here also. The curves are starting to separate before the medians and diverging further, but they are not separating beforehand. So there was a discussion whether you should directly start maintenance immunotherapy after completion of the chemotherapy, like we do in urinary bladder cancer. So that was discussed, but some trials were negative for that, and these 2 trials which we utilize routinely in our practice, they both utilized immunotherapy along with chemotherapy in a small cell. So I think it is not a uniform way in which we can tell that in all the cancers switch maintenance will work, whether it is concurrent maintenance will work. So we don't know. So this is where the trials are designed and get the approvals. So we don't exactly know.
We need to see the tail of the curve rather than
yeah, that is an important point, Samir sir, that yeah, curves are separating before median values. They are separating, and you can see at 1 year it is improved from 38% to 51%, and this is continuing to separate. And if you see towards yes, and duration response are good, and towards the end of the curve you cannot differentiate, because you can see the number of patients at risk are very low, 3, 2 and 1. So I think this is towards the end of the treatment completely for most of these patients, and you can clearly see the curves are separated. Until 18 months you have a large separation of the curves, median duration of responses are large, and hazard ratio of 0.7 in a patient with small cell lung cancer, the first line setting, seems to be very clinically significant and relevant for us. And this curve should continue to show improved OS at the updated analysis. You can see this 2 years data, 16 versus 22%, and further it lead to some improved PFS as well. But as I highlighted in immunotherapy trials, the PFS values are not so important. It is the overall survival, and especially the percentage of OS at particular time point, that is very important. So this patient had baseline nodal disease, bony metastasis, and whether should we give PCI regardless of choice of immunotherapy? Also, is there any role of thoracic radiation? So these 2 points are important. Darshit, can you discuss about the PCI?
Yes, sir. So definitely PCI has shown to have benefit. So yes, I would be recommending PCI post completion of chemotherapy, sir.
Okay, and Dr. Samir was?
There is data for MRI surveillance also. We show the MRI surveillance can also be used without using PCI.
Yes, so there is an option.
But that is technically very difficult in routine clinical scenario.
Completely agree. That is the point I wanted to bring. That is a Japanese trial which showed that MRI surveillance is an option, but repeatedly doing an MRI after every 2.5 to 3 months, it's actually very tedious, and MRI is not so easy as a scan. CT scan takes 5 minutes. MRI takes at least 30 minutes of dedicated time. So resource constraints will not permit. In our setup, even if the patient is affording, I will not recommend MRI brain to be done at every 2.5 months, because we have a limited slots of MRI available. We cannot waste for this surveillance purpose. purpose. If the patient is willing, they can do it any at other centers or outside the private centers, but we do not utilize our limited resources for MRI surveillance. So that is what is done in most of the setups as well. PCIs can be offered, and in this trial, 44 patients received PCI as a part of the treatment after the, but consolidative RT was not permitted. Any rationale for not permitting consolidative thoracic RT?
Probably because of pneumonitis.
Yes, very important. So immunotherapy trials will not permit consolidative RT definitely, because we know that immunotherapy is related to chances of pneumonitis, and we do not want an effective treatment because consolidative thoracic RT has not yet shown any significant benefit, and we have a dedicated immunotherapy trials which have shown OS benefit. So why not to give a treatment which is already proven, which has shown overall survival advantage, and why to utilize a treatment which can lead to interruption of the immunotherapy because of the development of higher risk of pneumonitis. So this is the 5-year survival data which has come up, the umbrella phase extension study. This is an extension study of IMpower 133, and here you can see this is long-term overall survival data has become available, 10 versus 12.3 months. You can see patients are ending in the placebo arm at just 33 months, and here some patients, that is the tailing of the curve which was being highlighted by Samir was, is being sustained, and you can see there are some patients even at the 72 months. So some patients are reaching up to 72 months mark, which is not possible with placebo. You can see at 33 months all the patients are having events. So this is what is important to understand. Some patients tend to respond very long to immunotherapy such like Atizo, and they tend to reach the 5-year mark. But yes, it will be a small percentage. It is 12% of the patients who are able to survive. We just discussed about the ELK. It was 60% and above, and here it is 12%. But yes, at least we can discuss 5-year survival with our patients. Otherwise, it is not feasible in disease like small cell cancers to have the discussion of 5 years.
That curve is very important because we discussed just few hours back, PD-L1 negative adenocarcinoma, 5-year OS was almost same. It was one trial like 18%, one trial was around 9-10%. So I think this is very good data. Yes. Means like out of 10, your one patient may survive for 5 years.
Correct. Completely agree. So 12% out of your 100 patients, if 10% patients are reaching 5 years, so this
without immunotherapy in small cell.
Correct. So this is the treatment options after progression. We tried to discuss it beforehand, so I'll not go into detail it now. But these are the various other trials actually which are in the either pipeline or some are under workup. For example, a skyscraper study where tiragolumab was added in the extensive stage. So that led to some improvement in the outcomes. So tiragolumab is a TIGIT inhibitor under development, and it has shown some positive results. Besides, we already are aware of the Caspian data. And there is also some more immunotherapy trials, pembrolizumab data, which came positive for PFS but negative for overall survival. So this is one of the rare trials where pembro came as negative. Otherwise, we see pembro, every trial comes positive. So this is one of the trials where pembro came as negative. So yes, frontline chemotherapy is the key to success. Hazard ratio 0.75, 0.76. If you see, the PFS and OS curves are very good. The benefit is that you are able to utilize carboplatin, which is the usual standard in our setups, which we have already discussed. It is another importance is that you are utilizing 4 cycles only. As I discussed, the chances it gives you an option to utilize chemotherapy of less number of cycles, so less toxicities, and grade 3 toxicities will be there with maximum with the chemotherapy partner, and this is expected. Brain mets asymptomatic and treated patients were allowed, and both the trials enrolled PS021 patient. Another advantage with IMpower was that it is a double-blind trial, so no chances of getting a false positive results in such trials. So that is the advantage of a double-blind study. It's difficult to conduct a double-blind trial. When we are conducting multiple trials at our institute, we are finding it actually very difficult, because in the double-blind trial there has to be 2 separate teams. One is completely blinded team that includes the PI and other investigators. One team is who administers the treatment is unblinded, because he or she has to know what is being administered. So that is important. So it's very difficult to conduct double-blinded trials, and this is very important. and this we have just discussed and covered. So I think we have covered the maximum points related, and the safety profile is already proven, and Atezo data is for 5 years is available, and never we have got such a good outcomes with a good tolerability profile. And I think atezolizumab is one of the preferred treatment options along with chemotherapy for our patients. With this, I can stop here. Thank you to the panelists for joining us and making this a successful discussion. Thank you, everyone.